So here I would like to mention that what do we mean by antimicrobial stewardship? We have already talked about antimicrobial resistance, how it develops, and now it is very important to understand that what stewardship means. So basically, antimicrobial stewardship is a coordinated program that promotes the appropriate use of antimicrobials, including antibiotics, improves patient outcomes, reduces microbiological resistance, and decrease the spread of infections caused by multi-drug resistant organisms. And stewardship also means that to identify that small group of patients who really need antibiotic treatment and then explain, reassure and educate the larger group of patients who do not need antibiotics. So basically, stewardship, the word stewardship means to protect something. It is a systematic approach to optimize the use of antibiotics. So what are the objectives of antimicrobial stewardship? Why do we need it in our setting? Antimicrobial stewardship is an interdisciplinary activity that promotes appropriate selection, dosing, route and duration of antimicrobial therapy. And why it is needed? As I have already mentioned, we need to optimize patient clinical outcomes and their safety. We need to optimize the use of antibiotics. We need to minimize antibiotic adverse effects and toxicity, and to reduce the selection of certain pathogenic organisms like Clostridiales difficile, reduce or stabilize antimicrobial resistance. We have to reduce the cost, and we have to implement site-specific treatment pathways based on the clinical guidelines. So these are all the basic objectives of antimicrobial stewardship. So here I would like to mention that AMS works hand in hand with infection prevention and control and environmental cleaning strategies. So antimicrobial stewardship in a facility not only decreases antimicrobial resistance, reduces C. diff infections, reduces cost, but it increases the good patient outcomes. It promotes antibiotic best practices, which is a first step in antibiotic stewardship. And it is very important to ensure that all the doses have been given properly and all the prescription orders have been written properly with the right dose, right duration and right indication for a particular infection. And we should get cultures before starting antibiotics. It is very important to emphasize over here that even if you are having a patient who is in severe sepsis and you think that patient needs immediate empiric antibiotic therapy, it does not take much time to collect a simple or single specimen for blood culture. So immediately draw a blood culture and start antimicrobial treatment. So take a antibiotic timeout, reassess the patient, reassess the use of antibiotic after every 48 to 72 hours so that we can judiciously continue with the antibiotic. And if we think that patient is not improving, either we can increase or switch the antibiotic to a broader spectrum one, and if we think that we have come up with a culture report, we can always de-escalate and switch to a narrow spectrum antibiotic. So antibiotic stewardship programs are basically a win-win for all of those who are involved in it. Here I would like to mention a very important aspect, and that is core elements of antibiotic stewardship. So there are many, and I would describe all of them one by one. The most important is controlling the source of infection. If we know that patient is having a particular source of infection, if we do not control the source of infection and continue using antibiotics, these antibiotics are not going to work actually. So the source control is the first step in the management of any patient. Prescribing antibiotics when they are truly needed. As I already mentioned, there are certain infections which do not need antibiotics, and we have to adopt the wait and watch policy. Like many of the seasonal infections or viral infections, they do improve with the passage of time, maybe after a period of 2 or 3 days, and such patients do not need any of the antibiotic therapy. And there are specific signs and symptoms which we have to look for carefully before prescribing an antibiotic when we suspect a bacterial infection. So prescribing appropriate antibiotic therapy and with adequate duration, using the shortest duration of antibiotic, which is evidence-based. Then reassessing treatment when culture results are available so that we can narrow down the antibiotic, and then supporting surveillance of antimicrobial resistance and healthcare associated infections. And monitoring of antibiotic consumption is very important, because by this way we can know that whether the antibiotics are being prescribed in a judicious manner, or they are being used empirically, or what is the consumption data tells us that how can we intervene and where we can intervene. Education of staff is very important, including all healthcare workers, not only the healthcare workers, I would say the education of the patient is also very important, because most of the patients think that antimicrobials are the only solution, and they start self-therapy while they are at home, or they use the antibiotics which have been prescribed to someone who is their relative for some other illness, and they think that they are having the same illness. So self-prescription of antimicrobials also contributes towards the development of antimicrobial resistance. So basically antimicrobial stewardship is supporting an interdisciplinary approach, and we have to enhance infection prevention and control, which is very important aspect of stewardship programs. So the effective implementation of antimicrobial stewardship program is based on the clinical science underlying the appropriate principles of antibiotic use, and it depends on collaboration between infectious diseases, pharmacy, infection prevention and control, clinical microbiology, information technology, healthcare administration. And it is also based on the knowledge of mechanism of action and resistance, pharmacokinetic and pharmacodynamics of antimicrobials, potential for adverse events, and the clinical evidence of the benefit. This slide shows the essential components of a stewardship program. So for a stewardship program, a leader can be a physician or a pharmacist, but it must need an administrative support. There should be a close relationship with hospital program with clear and overlapping goals. And as I already mentioned that it is an interdisciplinary approach, it needs collaboration with microbiology lab, quality improvement department, and with frontline clinicians. So the collaboration with all of them is very important to have an effective antimicrobial stewardship program in a facility. If we want to implement an antimicrobial stewardship program at a facility, we must design goals for that. We have to measure and optimize antimicrobial use. We have to minimize adverse events and resistance. And usually multiple strategies are used at once in collaboration with stakeholders to minimize the spread of resistance. Antimicrobial stewardship interventions can be financially self-supporting with the help of annual savings, and we should also aim to decrease antibiotic use by setting a goal of 20 to 30%. There are certain key factors in selecting interventions, and they are usually based on local antibiotic utilization patterns and data, local antibiogram, available resources, and what expertise are available. So antimicrobial stewardship program strategies include pre-authorization and prospective audit and feedback. These are very important two components on which a basic antimicrobial stewardship program will work. So pre-authorization means empiric antibiotics are started and workup for suspected infection is done. So what happens is that in a proper setting where antibiotic stewardship programs are in place, pre-authorization helps to identify that which infection is there and which antibiotic should be started empirically. So it helps a lot to identify a proper selection of antibiotic for a particular infection. So once a definitive infectious disease diagnosis is made, we can modify our treatment options, and if there is no definitive diagnosis made but continued suspicion of infection, we can optimize the use or we can de-escalate. And if there is no definitive ID diagnosis made but there is low suspicion of infection, we can even discontinue antibiotic. So decreased antibiotic resistance has been noticed with these strategies, and it did not result in any negative impacts. So what are the advantages of using different antimicrobial strategies? For pre-authorization, it can reduce the initiation of unnecessary and inappropriate antimicrobials. It can optimize empiric choices of antibiotics, and it can influence downstream use. It can result in reduced antibiotic cost. And what are the advantages of prospective audit and feedback? It is not only an educational benefit to the clinicians, but it can also address various other important issues. It does not result in delays in the first dose, as empirical choices are autonomous. It can de-escalate, it can help in de-escalation of antimicrobials on the basis of clinical data which is available, and there is more flexibility in the timing and the frequency of recommendations. So what are the disadvantages of these two strategies? For pre-authorization, it is real-time and resource intensive and impacts the restricted agents only. It addresses empirical use more than the downstream use, and there is loss of prescriber autonomy, and it may result in delays because the physician may think that he or she needs pre-authorization. What are the disadvantages of a prospective audit and feedback? They are typically labor intensive and they identify appropriate patients. For intervention, they may need tailored computerized system and which can be labor intensive as well as cost intensive. For facility specific clinical practice guidelines, they help to improve adequate initial therapy, standardize prescribing practices, incorporate local epidemiology, shorten the duration of treatment. It allows early IV to oral switch. Therapeutic drug monitoring is very important, and quantifying antimicrobial use. So these are the basic strategies which are required to minimize the overuse of antibiotic or to reduce the antimicrobial resistance. So these common clinical pathways can be used in cases of common infections like pneumonia, urinary tract infections, skin and soft tissue infections, and there are guidelines for surgical prophylaxis which can be adopted and circulated to all those who are working with the surgical patients. So this will help to optimize the empirical choices for patients who are undergoing surgeries. So we can also have prescriber-led review of antimicrobials. So antibiotics should be used only if they are needed, and this slide also emphasizes on the proper dose, duration, route, and the right indication of the antimicrobial agent for a particular infection. Another important thing is antifungal stewardship. We also know that there are various infections which are caused by fungi, and especially those patients who are at risk, particularly those who are in the oncology wards and those who are undergoing hematopoietic stem cell transplant and undergoing chemotherapy treatment, they are more prone to develop fungal infection. So antifungal stewardship is also very important. So we must consider local fungal epidemiology and antifungal resistance rates. We must establish treatment guidelines for febrile neutropenia, invasive candidiasis, like we can switch from echinocandins to fluconazole, either IV or oral therapy in susceptible isolates, and best available tests should be available for candidemia and invasive fungal infections. And unnecessary use of antifungals for contamination or colonization should be avoided. And as you know that there is no need to treat candiduria unless there is high risk of dissemination of the disease. So by adopting such kind of strategies, we can avoid unnecessary use of antifungals and antifungal treatment resistance. Those patients who are there in oncology setups and hematopoietic stem cell transplant units, prospective audits and feedbacks are very important in terms of antimicrobial use. Antimicrobial de-escalation strategy would be very important. Development of local guidelines will help to start or stop antimicrobials according to the existing rates and prevalence and incidences. Multi-pronged approach using prior approval and or prospective audit and feedback plus education would work better. Guidelines development for febrile neutropenia and antifungal stewardship must be in place. So there are various guidelines for antimicrobial use which are available online, and these guidelines can be used as a reference and they can be adopted as per our local antibiogram and the local prevalence of various infections. So this diagram basically shows that what is AWARE classification, which has been published by World Health Organization, and this word AWARE is the abbreviation of access, watch and reserve antimicrobials. This basically shows the classification of antibiotics for evaluation and monitoring use. In the access group, these are the antibiotics which are first line antibiotics and they have low resistance potential. In the watch group, the antibiotics included are critically important and they have high resistance potential. And in the reserve group, we have antibiotics for multi-drug resistant organisms, and these are basically the last resort antibiotics. So here the slide shows the antibiotics which has been included in access, watch and reserve group. You can see on the extreme left side of the slide that in the access group, the common antibiotics has been included, which have low potential for the resistance, and they can be prescribed by anyone. Those who are suspecting some simple infections where resistance is not that common. And here you can see that antibiotics like amoxicillin, clavulanic acid, penicillins, first generation cephalosporins, tetracyclines, sulfonamides, trimethoprim derivatives, then sulfonamide trimethoprim combinations, nitrofurantine derivatives, and aminoglycosides has been included. In the second group, which is called watch group, second generation cephalosporins, third generation cephalosporins, and fourth generation cephalosporins has been included. In addition to those antibiotics, azithromycin, ciprofloxacin, piperacillin tazobactam, carbapenems, vancomycin and fluoroquinolones fall in the same category. There are certain antibiotics which are reserved for very serious and severe infections, and they are categorized as reserve antibiotics. And these include aztreonam, ceftazidime avibactam, ceftaroline, colistin, daptomycin, intravenous fosfomycin, imipenem, intravenous polymyxin and tigecycline. So these are the antibiotics which have to be used very carefully and consciously, and where they are needed, they should be prescribed. They are not for common use. Antimicrobial stewardship basically is based on safety, quality and equity dimensions. So we have to ask ourselves that does our organization keeps up to date with the latest evidence and strive to innovate and implement that standard of care? This is called quality, that is aspiring to the best possible quality and effectiveness of care. The second question is that, is there a systematic approach to ensure each patient using antimicrobial is managed with the principles of antimicrobial stewardship, ensuring every patient, regardless of their cultural or linguistic background, has the same experience of care, which is called equity. And the third component is safety, that is bring up to the minimum acceptable and sustainable standards. Has the right patient been prescribed the right dose, right duration and the right antibiotic for a right infection? This is a very important slide, and this basically shows that what antimicrobial stewardship program contains. It has two very important components in its structure. One is antimicrobial stewardship committee and one is antimicrobial stewardship team. Basically these two areas are very, very important because they have to work in close collaboration with other people to implement all those interventions which are required to reduce antimicrobial resistance. So here you can see that antimicrobial stewardship committee basically includes a larger number of participants. It includes all the heads of departments. Healthcare facility leadership is very, very important part of this committee. Drug and therapeutic committee, patient safety committee and IPC committee are part and parcel of antimicrobial stewardship committee. Whereas AMS team is rather a smaller group of people, and this includes champions from antimicrobial stewardship. It also includes members from antimicrobial stewardship committee, microbiology people, medical practitioner. It can have pharmacist or any nurse or any surgeon can be part of the team. So basically these very important or essential I would say members of the team, they would work in collaboration with other departments to implement the specific interventions desired for implementation of a proper antimicrobial stewardship program. So antimicrobial stewardship program should be at national level. It can be at tertiary care hospitals, at hospitals and other health facilities, and AMS program for outpatient facility and AMS program can be tailored according to the resources available and according to the environment, like where we are going to implement it, and it can be even outpatient setup. So this slide is basically showing the National Antimicrobial Stewardship Program. I am not going into the detail of this because it is beyond the scope of this topic, but it is just showing the steps which are required for establishing National Antimicrobial Stewardship Program to enable a facility level antimicrobial stewardship. This another slide is also showing the key steps to establish healthcare facility AMS program, and this slide I would say is very, very important because it shows certain important enablers for effective antimicrobial stewardship program at the hospital. So AMS program should have clear organizational structure and governance. There should be somebody who is executive, and a clinical leadership is very, very important. AMS advisory committee should be there, and multidisciplinary clinical AMS team should be part of it. So they can get expert advice from infectious diseases experts, surgeons, practitioners, microbiologists, pharmacists, nurses and antibiotic champions. Education and training is very, very important for proper implementation of antimicrobial stewardship program. And it is not only for the prescribers but also for pharmacists, nurses, and for the consumers. And information technology resources are also very, very important because you can always get data and track back to see that what practices are being done in the hospital. Okay, so this slide shows the essential strategies for antimicrobial stewardship program in the hospitals. So this includes pre-prescription strategies and the post-prescription strategies. For pre-prescription, there should be some formulary management. As I already mentioned that proper implementation of 5 Ds are very, very important. There should be restriction systems in place, that there should be some pre-authorization, and if antibiotic is not needed for certain kind of infection, that antibiotic should be restricted to be used by the prescriber. So clear clinical guidelines should be made available to all of those, especially for empirical choices and for prophylaxis. Education must be an ongoing activity. Antibiograms which show susceptibility of microorganisms to antimicrobials in a particular setting is very, very important because we can tailor our empiric choices for therapy as well as for other infections as per antibiograms. Then there should be selective reporting of susceptibility testing, and patient's allergy status should be confirmed before starting antibiotic. As far as the post-prescription strategies are concerned, there should be some direct patient inputs, antimicrobial stewardship rounds should be made, audits and feedbacks should be done, and monitoring of appropriateness of antibiotics should also be done. As per National Antimicrobial Prescribing Surveys, we should monitor utilization, and then education and electronic system can tell us that how many antibiotics has been used and how much of the antibiotics has been used and whether they were prescribed for a right indication or not. So basically the electronic surveillance programs would help a lot in this regard. Then IV to oral switch is also very important to be noted, that whether the right or appropriate switch for antimicrobial was done or not. So IPC and AMS in delivering quality healthcare and optimizing antibiotic use is very, very important. And this slide basically shows that how important is antibiotic consumption data. It is not only the usage of antibiotic by the patient, but it just starts from research and development to manufacturing and then to the market registration and then selection, pricing and reimbursement, procurement, and then prescribing of that particular antibiotic, dispensation of antibiotic, and then appropriate use at the patient level. So this all data is included in antibiotic consumption data, and this is very, very important to know that how antibiotics are being produced and how they are being utilized at the facility level. And this can help us to identify the data, and then subsequent strategies should be based on this data. So antimicrobial stewardship can be beyond the hospitals. Even in the community, we should advise the patients to know that what is important for them or what is not. As I already mentioned, self-prescriptions should be discouraged, and we should not prescribe antibiotics for the colds and flu. And we should adopt strategies of delayed prescribing, because sometimes most of the infections they improve themselves. There should be a shared decision making, because we should take patient in confidence that patient is not suffering from any serious illness, patient is having some viral illness which will improve itself. So if the patient is convinced and listens to that physician, then it will definitely help us to reduce the unnecessary use of antimicrobials. Then there should be public declarations in the practice about conserving antibiotics, and we have already noticed that during the era of COVID, mostly antibiotics were used unnecessarily without any indication, because the patients were in fear that they are probably suffering from severe bacterial infection, they must use antibiotic. So that was a wrong practice, and this practice should be discouraged for various viral infections. Then pharmacies should offer symptomatic support for cold and flu, and in home the patient should be advised not to take antibiotics that have not been prescribed for them, and they should discard all antibiotic medicines appropriately.